Welcome to American Journal of Sports Medicine Top Cited Article Series. And today we have the top cited article from 1980 in AJSM, which has been cited almost 1,000 times on shoulder impingement syndrome in athletes. This article was written by Dr. Rich Hawkins and Dr. Kennedy back in 1980. And Dr. Hawkins, thank you so much for your time and be able to talk a little bit about your article today.
Well, I'd love to chat about it. This is over 40 years ago. You're challenging my memory.
And the first question I have for you is, how did you come out with the idea of shoulder impingement back in 1970s and publish this article in 1980? Because back then this is a pretty new concept, where it is very common now in the 2022 for shoulder pathology.
Well, it was new for many people, but was not new for Dr. Neer. And I was his first fellow in 1975. And this is only 5 years later that we published this article. So he published his acromioplasty article in 1972. So he had already popularized this concept he had of impingement. And I, being his disciple, picked up on that. And I was very involved in sports in Canada, where I practiced with Dr. Kennedy, who was a very famous sports knee surgeon. So we got onto the idea that maybe this would be applicable in athletes. So having that expertise, if you will, and background with Dr. Neer and association with Dr. Jack Kennedy, then we wrote this paper on impingement in the athlete. And even to this day, this impingement subacromial concept and anterior acromioplasty remains very controversial, although I don't think it should be.
And can you just discuss a little bit of the diagnosis and stage of shoulder impingement and the Hawkins sign, and how did you come up with your own sign and, back then to make this diagnosis?
Well, yeah, so the importance of this paper was, and we published, by the way, in 1988, the next fairly large volume of patients who did not have a cuff tear who had an anterior acromioplasty. So we were onto this early on, that impingement being a problem. And we knew then that it was critically important to get the right patient and make the appropriate diagnosis. Dr. Neer described the impingement test where he injected xylocaine in the subacromial space. And if that took away all the impingement size and eliminated the pain, then he called that a positive test, and thus the diagnosis of impingement. Now, this is speaking in the absence of a rotator cuff tear. Keeping in mind in 1980, we did not have MRIs then, only arthrograms and physical exam. So we selected our patients very carefully, and thus was the source of making the diagnosis, particularly with impingement signs and Dr. Neer's impingement test I just described. And we did arthrograms to rule out a full thickness tear. So we focused this group of patients as being athletes, as opposed to the general population.
And how do you say in 2022 and 40 years later, how do you, has the impingement syndrome diagnosis changed since you wrote this article, Dr. Hawkins?
Well, I mentioned the word controversial, and you probably understand that in the coding and billing, you cannot bill an anterior acromioplasty for impingement in isolation. There's a bunch of doctors that got together and they had some type of vendetta that they thought there were being too many acromioplasties being performed. And they can be abused. For sure, maybe a lot of people were not appropriately selecting the patients. And so they went on the warpath and they convinced the coding people to eliminate being able to charge for it. And here is probably one of the best operations we have. I've done thousands of them in the right patients that had a good response to it. Impingement test by Neer and the appropriate physical signs and the appropriate age and all that without a cuff tear. So we did an acromioplasty, and they were highly successful. Now in the athlete, this has come along maybe not to be so successful, particularly in overhead throwers. So Jim Taboni published Frank Jobe's work, and they're getting throwers back with an acromioplasty wasn't so successful. And that's when Dr. Jobe came up with his anterior capsular labral reconstruction for subtle instability rather than impingement. So that swung the pendulum toward instability as a diagnosis for shoulder pain in an overhead athlete rather than impingement. Now, that's strictly speaking of athletes and pitchers that Dr. Job looked after. So I've performed this operation thousands of times and been highly successful. If they had a good injection, a responsible injection, the appropriate impingement signs, the right age group, the right patient, their chance of getting relief of pain with an acromioplasty approach 90%. That's pretty good odds. And then people decided, well, you can't charge for that anymore. So that was really sort of an interesting happening in our coding and billing. And it hasn't happened with anything else, although there's some threats for doing this with hip scope work. But anyway, and then you did ask about the Hawkins side. I should profess here that this was really Dr. Kennedy's and Dr. Peter Fowler's sign, where they took the atom, put it in the four-plex position, and forcibly internally rotated to drive the graded tuberosity under the coracoacromial ligament, causing pain. That was just another impingement test that we did, or an impingement sign. It really shouldn't be called the Hawkins test, but it's the old story. Take credit where credit's not due. It wasn't my idea, but my name seems to be attached to that test. Really belongs to Dr. Kennedy and Dr. Fowler, my partners in London, Ontario.
Yeah, and when you go back to about subacromial decompression, back in 1980s, were you doing these open, I assume? Or there's no scope, and then how are you doing them?
So we did these open, and the first paper I published in '88, which was the second paper to be published on anterior acromioplasty after Dr. Neer's paper in 1972. We were doing open acromioplasty at that time. And again, we had about an 87% success rate. Again, given the right patient, good response to an injection, and in the appropriate age, and no rotator cuff tear. Now, that was not an athlete necessarily. That was all comers. So again, it's a matter of patient selection, and somehow or other, it's fallen into disrepute with some doctors. I know that I have a couple of sports friends that you wouldn't even mention impingement in their sports clinic, or they'd throw you out. Now, I don't know how they got misled in all this. There's no question that the rotator cuff starts to fail in life, whether it's age-related or whatever. And as you know, when you get older, it goes right through the full-thickness tear. Somewhere along the way, the cuff fails, the head rides up, and get partial tears, whatever. That's when impingement occurs. And that's when maybe we can intervene to decompress and free up that impingement and stop progression with an anterior acromioplasty.
All right. And is there any other key points of the shoulder impingement that you learned in the last 40 years you'd like to share before we end this interview?
Well, we're back to patient selection, the right patient with all the things that I've described. Keep in mind that we didn't have MRIs. Now we have MRIs, and we can rule out certain other things. In the athlete, we now have what's called internal impingement, where one takes the arm up in external rotation abduction and stresses it up there, and it hurts the athlete, and we push back and it takes away the pain. That's where the posterior superior cuff is being impinged. That's where they get partial undersurface cuff tears. So that's different from Dr. Neer's anterior acromioplasty routine position in the rotator cuff. People confuse those two, and they shouldn't. So now we have another different diagnosis. The other thing to keep in mind, we've now learned over the last 10 years that the biceps tendon, if it's pathological, can cause pain. And it's very common for it to cause pain in almost anybody if it's pathological. So we now have the option of dealing with the bicep, like John Elway won 2 Super Bowls after we got rid of his biceps, actually ruptured. Brett Favre had an operation to get rid of his biceps, and when we got back in the NFL. So we learned in these athletes that we could do this. And those, when we look at failures in our acromioplasty over the last 20 years, it was usually because they had a bicep problem. So now we have the advantage of a good diagnosis of impingement. We can now deal with the biceps if we need to as well. We can do a tenotomy, tenodesis. In younger patients, we probably avoid that. But in older patients, don't hesitate to cut the biceps because it's such a source of pain. It may be made more pain-producing than even the cuff under the acromioplasty.
Well, that's a really good point, Dr. Hawkins. And, I thank you so much for your time and, your knowledge on the impingement syndrome over the last 40 years, and really has, changed our field, and especially on this topic and what you shared with us. So, thank you so much again for your time.
You're very welcome. You're very welcome. Ask a bunch of doctors. You'll probably get different opinions on this. But Tiger, thanks very much for doing this.
Yeah,
Take
thank you
care.
so much. Yep, you take care. Bye.
Bye-bye.